Good morning. My name is Joanna Bergeres-Tilita, and I'm an anesthesiologist and intensivist in Bern, Switzerland. I would like to thank Dr. Pablo Cardinal and Professor Francesca Robulotta for the invitation to speak here today. I'm going to bring you two original papers in gender equity, which I co-authored with my colleague from Slovenia, Marko Zdravkovic. So regarding gender equity, as you may know, gender diversity in decision-making and participation in the workforce results in stronger economies, more productive institutions, and more stable governance. Gender parity also maximizes academic productivity, and peer-reviewed publications with gender-diverse authors receive more citations than publications produced by single-gender authorship team. Moreover, it has been showed that gender diverse groups collaborate more effectively and exhibit higher collective intelligence. In medicine, gender diverse teams have even a direct effect on patient outcomes. For example, a 2018 study cited here below showed that female patients with acute myocardial infarction had higher mortality when treated by a male doctor than when treated by a female doctor. And this effect was attenuated when the male doctors had more female colleagues and patients. Not to mention another study from Canada published in the JAMA involving 3,000 surgeons and more than 1 million patients that showed that women were 15% more liable to suffer a bad outcome and 32% more likely to die when a man rather than a woman carried out the surgery. So addressing the current gender gap in medicine will improve working conditions for all physicians, contributing to a more stable workforce. But unfortunately, there is no magic pill, and research is still lacking regarding the effective strategies to reduce discrimination. And this is what we wanted to know in this 2020 publication that came out before the pandemic. So we gathered data on more than 10,000 acute care physicians worldwide, and we aimed to include data from 148 countries with a good proportion of respondents, around 50-50 women versus men. And we found, similar to other studies, that women were more likely to be discriminated against and mistreated in the workplace, and that being a woman was a clear disadvantage in reaching a leadership or investigative position. Importantly, as anesthesiologists, women were less likely to have children and therefore to raise a family compared to men. We also analyzed the open-ended replies using a qualitative methodology, and after thematic analysis, we decided to group answers according to complexity levels, worth mentioning here. At the most basic and central level, participants indicated that one of the most important aspects to bring about the neutralization of inequality is actually to set an example. And this implies being attentive and reporting equality situations, supporting colleagues to promote a good professional environment in which everyone has the same opportunity. On an institutional level, there were some measures that were mentioned, which include both equality measures, namely concerning social indicators, that is, that the necessary opportunities are equal for both genders, that pay gap and working conditions are equal for both. And on the other hand, they also suggested measures of equity, that is, of social justice, in which there is added protection for the period of pregnancy, maternity, and returning to work after birth. The second study I bring here is on regulations of anesthesiology training programs that further addresses this topic of family-friendly practices during training. This has been recently accepted in the EJA, and hopefully it will be published soon. In short, this is the first descriptive study reporting on the characteristics of anesthesiology training programs across Europe, focusing on welfare practices. And with this study, we aimed to describe the work regulations of anesthesiology training programs and working conditions during the child rearing period, by which we did a cross-sectional survey and used a questionnaire to gather information on several countries particularly by asking the NASC representatives of the European Society of Anesthesiology and Intensive Care. Our main outcome measures included basic specialist training working conditions, gender-related data, work regulations when returned to work after childbirth, and some policies against discrimination during training. We had a median proportion of female trainees of 60%, which is much more than in other Western countries, being the highest proportion in Montenegro, with almost 90% of residents being female, and Bosnia and Herzegovina with almost 80% of residents being female. In 11 countries, there were specific training programs for leadership skills, and in 2 of them, particularly Denmark and Sweden, specific training in leadership skills for females. And we also found that the proportion of female trainees was negatively correlated with the GDP per capita. So in countries with lower GDPs, there was a higher proportion of female residents in training. In 8 countries, trainees legally worked fewer hours during pregnancy comparing to their non-pregnant counterparts. Pregnant trainees could be exempted from on-call shifts in several countries, including Belgium, Bosnia, France, Italy, Kosovo, Moldova, North Macedonia, Serbia, and Slovakia. But in the remaining countries, they could only ask to be exempted by presenting a doctor's declaration. Pregnant trainees were legally excused from night shifts at 24 weeks in median, and they could not be fired during pregnancy across all countries in Europe. Returning to work after pregnancy also seemed to be challenging for trainees, with only half of the participating countries allowing for part-time work after birth, 22 countries accommodating reduced working hours, and only 26 relieving mothers from working night shifts. Overall, only a few countries, these ones in yellow, offered the 3 possibilities to return after childbirth. Regarding breastfeeding in the workplace, this was very interesting. Denmark, Finland, Iceland, Sweden, and the UK do not have formal legal dispositions for breastfeeding in the workplace. However, on the other hand, despite having legal regulations, Albania, Bosnia, Cyprus, Georgia, Hungary, Kosovo, Lithuania, Montenegro, and Slovakia reported that breastfeeding during specialist training does not occur, although there are legal regulations protecting for it, because they usually do not have facilities in the hospitals that allow women to breastfeed. And finally, regarding zero tolerance, well, probably the most important step that one can take is to have zero tolerance for discrimination. This zero tolerance approach may include issuing guidelines and enforcing accountability. However, if we look at how many anesthesia societies in Europe have put this into practice, the results are more disappointing. We only have 6 intensive care societies, while the Scandinavian is joint venture, so to speak, have issued gender equity statements. So finally, there is a large limitation to studies on gender equity, including these 2 that I presented to you. Gender equity can only be investigated based on social research methodology. And this is so far regarded as lesser science. So projects regarding gender equity in medicine end up being rejected in anesthesia journals and published in journals more focused in social sciences, which are less read by anesthesiologists. So a part of changing the mindset will also include publishing more qualitative analysis papers, which are a validated methodology. So thank you so much for your attention. And now back to Francesca.